much, Bill. We are very fortunate in our area to have Overlook Hospital and, of course, Morristown Hospital, the Atlantic Health System. I've spent, of course, my whole career in healthcare, and both hospitals are spectacularly good. And we're fortunate today to have two speakers, one from the Overlook Foundation, Clelia Biamonti, and the Chief Operating Officer, Lauren Yedvab. In terms of their history, Clelia has served as the Executive Director of the Overlook Foundation since 2017. She had previously been on the Foundation's Board of Trustees for 7 years, including 3 years as Chairman of the Board, while being a Senior Principal at the Bluefin Group, a management consulting firm that serves the biopharma industry. Prior to that, she was a managerial consultant for Coopers & Lybrand, and later PricewaterhouseCoopers. A resident of Summit, Clelia has received a PhD in biochemistry from UND Rutgers and a bachelor's degree in philosophy from Mount Holyoke. In addition to work on the Overlook Foundation Board of Trustees, she's a member of the advisory board for Columbia University's bioethics program, served as president of the Board of Trustees for New Eyes for the Needy, a former member of the Board of Trustees for the Discovery Orchestra, and she's been honored by the Boy Scouts, a very, very busy woman. Lauren Yedvab joined the Overlook Medical Center as the Chief Operating Officer in May of 2019, just about a year. Previously, she held positions in Northwell Health as the Assistant Vice President of Brooklyn Region and Deputy Executive Director of Lenox Hill Hospital. She began her career in New York Presbyterian Brooklyn Hospital as an administrative fellow and was promoted over the years, eventually being named the Chief Operating Officer. She's a graduate of State University of New York, Oneida, and received a Master's of Health from the Sloan program at Cornell, and is an active member of its alumni board. She was named one of Crain's New York's Business 40 Under 40 Rising Stars in 2005, and the following year listed as one of modern healthcare's up-and-comers. In 2019, she was honored by the State University of New York, Oneida as an Alumni of Distinction. She has held board positions for the Metropolitan New York chapter of the American College of Healthcare Executives and the New York chapter of the Health Financial Management Association. Very, very accomplished woman. I turn the program over to them.
Thank you so much. I'm Clelia Biamonti, and this is Lauren Yedvab, and we're really pleased to be here today to talk to you a little bit about Overlook, what's been happening since we last met about 19 months ago, and we'll tell you about our COVID story. It's quite a story to tell. So Overlook Foundation, for those of you who are not familiar, is the charitable arm of Overlook Medical Center. Our purpose is to support innovation of all kinds here at Overlook. We have been supporting Overlook since 1976 and have donated well over $200 million during that time. We are in the midst of a large capital campaign to completely renovate every square inch of this facility. And we're doing very well with that until COVID hit. And then, of course, not only did construction halt, but major fundraising did as well. Our plan all along has been to create a lot of flexibility in the way that we care for patients at Overlook. And what I mean by that is, depending on your acuity, we could adjust the care around you instead of moving you from room to room and place to place in the hospital. And we were really doing that to design what we like to call the hospital of the future. In 2005, Medicare really changed the way that reimbursement worked for hospitals and for physicians. And what they tried to do was lower the cost of care by creating incentives to move care of the patient into the outpatient setting much closer to home. It was ultimately more expensive for them and more lucrative for physicians. So hospitals became smaller. They certainly focused on acute care versus wellness. And we were thinking, well, maybe that's a good idea. So how do we align care with the way that reimbursement flows? That was all well and good until COVID hit, and we realized you really can't have that small of a hospital because we need to prepare for waves of crises, whether it be a pandemic or something else. So it turns out that the design plans we had were spot on with the kind of hospital we need for the future, with a few exceptions that we'll talk about shortly. But one of the things that was most important in designing a hospital that was flexible is not just the building itself, but the team structure. We have been working to become what's known as a high reliability organization, where we are functioning at high capacity all the time. And that training was really pivotal in our success in helping the community through COVID. We saw our first patient March 7th and spent the few weeks prior to seeing a first patient really worried about how will we accommodate 5 patients? What if we have 10 patients? Well, at our peak, we ended up having over 309 patients at any one time. And I'm going to let Lauren tell you a little bit about that, but her expertise of working in 2 such prestigious New York hospitals, I would really say helped amp our game substantially in the way that we dealt with this crisis before, during, and now afterwards. Her nickname during this is the Queen of Clean. As part of operations, it's obviously very important to keep us safe as healthcare providers, as well as the community at large. So I'm going to turn it over to Lauren to tell the story a little bit of what happened between March 7th and today, to tell you about all of the great work that happened here.
Thank you. And thank you for inviting me to participate in your meeting. First and foremost, I should tell you, because you've talked a little bit about my bio and that I've spent my entire career in New York and in New York City, I have to first and foremost tell you how happy I am to be here now. And I've received a lot of calls over the past couple of days saying, Lauren, are you not really, really excited about not working in Brooklyn right now, a few blocks away from Barclays Center? Yeah. And yes, the answer is absolutely. So yes, I do have a lot of experience in terms of emergency management. We don't really talk so much about emergency preparedness because you never really know what you're preparing for. So we talk more about making sure that we have plans in place for emergency management so that no matter what comes our way, we have the ability to respond. So at the very beginning, back in March, Alan Lieber, our president, came to us and said, I think we're going to need to have to increase our capacity of ICU beds. And New Jersey had done a lot of pandemic planning and estimated that we would probably need to triple the size of our ICU. And so we didn't necessarily get quite there, but we went from 40 ICU beds to 105 ICU beds. And that is not an easy feat, except for the fact that we had a lot of flexibility. And yet another reason why I was happy not to be in a landlocked inner city hospital, because our rooms were actually substantially larger, which enabled us to flex up and do that. But with that, and with preparing, we, by the way, actually took care of over 1,000 patients with COVID since this started. I'm very happy to tell you that now, because this is where we need to, assure everybody, we have less than 30 patients in-house with COVID, and they are in defined units. So they are isolated from everybody else. So we are open for business, and we'll get a little bit more into that later. So we did have a lot of scarcity of resources because we were not necessarily prepared to take care of 105 critical care patients on ventilators. So PPE was actually one of the focuses at the very beginning. So masks, surgical gowns, gloves, the N95 masks. Which masks should we be using? And then there was the idea that we had negative pressure rooms, but they were scattered throughout the hospital. And so what we very quickly figured out was that we needed to create negative pressure rooms in all of our rooms in the entire hospital. So we have a remarkable engineering team and facilities team that worked tirelessly at the very beginning, and really miraculously, to be honest with you, by being able to go into rooms, go into the ventilation system, put in what we call a scrubber. And what that did was not only did it provide a HEPA filter for the room, but it actually also created negative pressure. And so we were able to convert rooms that never had that capacity, and overnight we were able to create entire negative pressure HEPA filtered rooms throughout the hospital. So we did that a lot. Some of the other things that we had learned from other places was that the nurses would have to go in and out of a room multiple times to check vitals, to take care of patients, to check and look at monitor settings and infusion pumps. And what we learned is that if we put all of that equipment in the hallway and actually just created a hole to get the tubing or the connection to the patient, all of that could be done in the hallway and not requiring a nurse to don and doff, that's a new concept, all of their PPE every time they walked in and out of a room. So that was actually something that was really, really remarkable in terms of our impact in reducing the amount of wasted PPE that we had. Our registered nurses and the teaming, and I think Clelia mentioned this before, when you go from 40 ICU beds to 105, we don't necessarily have critical care nurses to staff all of those beds. So what we did was, one, we had a lot of training going on very quickly at the beginning, but we teamed our critical care nurses with med-surg nurses and our operating room nurses and shifted gears and really provided the resources where they needed to be. Our intensivists, we obviously did not have the intensivist staff to take care of all of those patients independently, but we had the most remarkable team approach. So we had our chief of cardiology who said, you know, I don't really feel comfortable taking care of or monitoring ventilator settings, but if you told me what to do as a resident, I could do that. So we had the most qualified chief residents in-house that you could possibly imagine. Our surgical attendings were all very excited about participating because we didn't have them in the operating room, because very quickly after this started, we had to cancel all elective or scheduled procedures. So all of those resources were shifted over to care for our inpatients. Ventilators, you know, there was and I don't really want to say this publicly, but I will. There was a scarcity of resources when it came to ventilators, and it got to the point where our Atlantic Health leadership, Brian and Amy, were reaching out to colleagues and friends outside of New Jersey to say, hey, we're in a real hotspot and we need ventilators. And so we were getting loaners from Johns Hopkins, from Children's Hospital of Philadelphia, and they were really all coming into Atlanta. Yes, we got from Atlanta as well. And so we went from probably having about 48 ventilators in-house to about 120, you know, to the tune of, you know, we probably had 30 ventilators that were waiting in case we needed them that we never ended up having to need at all. So that's all real helpful. And, you know, so what do you learn from that? You learn that there's, you know, some benefits of having some stockpiling. You know, we don't know in terms of anticipating any type of resurgence or a surge. Again, engineering is a firm believer that they would much rather look at the stuff than look for it. So true. We have those scrubbers, which have now been removed from most of the rooms because, you know, week after week, as the numbers came down, we actually were able to shift and keep all of our COVID patients on specific units and reconvert our units back to clean or non-COVID units. And what, you know, what's entailed in there, that's where the clean of clean comes in, that we removed every piece of equipment, resource, supply from the room. We removed the air handling system, and all of that was taken by engineering to be disinfected, sanitized, sterilized. And before anything went back in the room, all of the walls were washed, the window treatments were removed. All of the equipment and furniture had all been completely decontaminated, replaced. And
pillows thrown away.
Yes, they throw out the pillows. By the way, think about that the next time you go to a hotel. They threw out the pillows. And, you know, all of the linens had been replaced. And so when we went back in, the nurses, you know, there was such a sense of confidence and calm and reassurance that they knew that there was no COVID in this unit whatsoever. And, you know, that really does promote really engaged and safe and reassured staff. So we've done that on unit by unit by unit as we've reintroduced surgical procedures to the hospital, so that we have our orthopedic patients are now back in their unit. Our bariatric and general surgical patients are back in their unit. Oncology, everything is back to where it was, and it's probably better than it's ever been. You know, the real fundamental thing, and my other nickname during this has been Lauren the Lab Lady, because I happen to oversee laboratory services for the entire health system. And it really all came down to the test. And when this all first started, if you recall, a patient would come in with respiratory symptoms that we were all familiar with, right? And we would have to run through a lot of rule outs before we got the CDC to say, yes, send us a specimen. And so we were first sending it to Georgia, and then we were sending it to the state. And that result could possibly take, we just lost out.
Oh, I got it. They can still see us.
Oh, okay. That they could, it could take 3 or 4 days before we had a result. So for those 3 or 4 days, we had a patient in a rule out status where we were treating their signs and symptoms, but we didn't necessarily know whether or not they were positive for COVID. And that has transitioned all the way to the point where we have point of care testing available here, where you'll have a result within 45 minutes. So that's a game changer for the hospital. So we do have that point of care testing, but there's a limited capacity there because the company had not necessarily realized that they were going to have the end all be all, and they haven't been able to manufacture enough. But we also have redundancy because at this point we wanted belt and suspenders. And so we have point of care testing. We have also additional testing at our consolidated laboratory. We do use several reference laboratories as backup for a high volume of testing as well. And then we have the same machine that they have at the reference test, we have on order that we'll have it here as well. So that we'll be able to run thousands of tests at any given time as opposed to running one at a time on our point of care testing. So we've really made a tremendous amount of investments and have become essentially in a very short period of time a market leader in laboratory science. And you know, so we're ready for a resurgence, but we sure hope it's not going to happen. The last thing that we're doing is actually a study across the health system, which is 22,000 individuals are being tested for antibodies. And that is really more of a study because we're still not really sure what those antibodies mean at this point. It does not mean immunity, and it does not necessarily mean that we know how long those antibodies are going to stay in your system. But we are doing a study to find out really, and to demonstrate so far what it's demonstrating is that the PPE actually works. So we've learned a lot. You know, it's incredible that, you know, a couple of months ago, no one had ever known what COVID-19 was. We went quickly from learning what coronavirus was, the common cold, to now actually knowing differences between antigens and antibodies and, you know, how to prevent the spread of illness. And hopefully, you know, other than our social distancing,
Right.
you know, I'll miss, you know, not shaking someone's hand and that contact, but hopefully we find our new normal.
I think a couple of things to note was I mentioned that we had become, as part of the health system, a high reliability organization. And I really do think that was critical in us having no preconceived notions about what this would be like. There were no egos involved. So when Lauren mentioned that our head of cardiology became a resident, that was set the tone for a lot of other people saying, well, I don't really know how to admit patients in Epic, which is our medical record, but if you teach me, I can do that. So we had neurologists admitting patients. We had pulmonologists training other people. The collapse of ego and then was critical, I think, in helping expertise spread rapidly across the organization. You know, we have our own MacGyver, Austin Murphy, who runs clinical engineering, and just his constant attitude that we can do this. We may not know what the answer is, but together we'll figure it out. And so when Lauren mentioned that he converted entire units overnight, I mean, people woke up in town and were posting on Facebook, what are those silver things sticking out of Overlook? What's wrong at Overlook? I think we did a great job at keeping ourselves and the community calm. To some extent, they had no idea what was happening here, which was excellent. But for, you know, an entire section of the hospital to the next day, people wake up and there's silver things sticking out was, I mean, he had to cut into outside walls. Really, again, that attitude of, we're just going to get it done because our patients need us. We had at some point erected 4 tents
Right.
To help keep patients who were potentially COVID positive isolated, to help people who were waiting in the community hear about what was happening to their loved ones. We also had a very strong palliative care program here for a long time, and really those people were all redeployed to help keep family members calm and patients calm. It was really all in for Overlook all the time, and it was an honor to be here on the outside and to really watch all of that happen. We've also participated in 5 clinical trials, which many of you know, the hydroxychloroquine, both with and without azithromycin, the remdesivir trial, the Actemra trial, and then proning patients, turning them upside down to let their lungs oxygenate. And I believe there are some others happening now. Overlook Foundation is actually going to start sponsoring a trial in neurology because people are now saying, you know, COVID is a blood vessel disease. So how do we look at that and maybe explain the strokes that we're seeing in younger patients? One thing I think the nation didn't expect is that we would joke that COVID cured heart attack and strokes. You may know that we are a neuroscience center of excellence in the country, one of the top 5. And so we were very, very afraid, how are we going to continue to manage our critical care neuro program for strokes and aneurysms while we're having hundreds of COVID patients? Well, they stopped. There were no heart attacks and strokes. And it was really a saving grace for us because we could convert those ICU rooms and those resources to help support the surge of really sick people here. I can tell you, I would really, based on what I saw personally, never get my health care anywhere else. The quality of the expertise, the attitude that we can get anything done if we put our mind to it, and the true caring of the people who live around us, I think set us apart, and it's something we'll never forget. I do want to spend a few minutes just talking about the extraordinary community response. When it was clear in the community that we had COVID here and that it was no longer a, did you meet somebody from Wuhan at a party and are you sick, but it was in the community. Groups started popping up called the Frontline Appreciation Groups. We had one in Summit, one in Berkeley Heights, one in Short Hills, one in Westfield, and they started daily meal trains. So literally the next day, hundreds of meals would arrive here from the community around noon and around 7 p.m. And then it would be rotated around the units. They would raise money from the community and then in turn shop at local restaurants to help support those local businesses and bring the food here. And the Summit Police Athletic League was really critical, and delivering the meals as well as working with our own team. You know, it was all hands on deck, and all of a sudden we had 500 meals coming here every day, and food management was extraordinary in really just saying, okay, we're just going to add this to our workflow. Balloons, pampering items for the staff, flowers, handmade masks, headbands, because you know it really does hurt to have these things in the back of your ear after a few hours, headbands with buttons on them. Amazon wish lists. It was just an extraordinary response where people felt they wanted to help and found very impactful ways to do that. And we hope to have an unmasking celebration one day where our team can come out without a mask and properly say thank you. But it was an enormous morale booster. We're not used to taking care of this many critically ill patients at one time who don't have any family member at the bedside to speak to bring comfort to. So not only were we caring for everyone in a clinical perspective, but every caregiver had to provide emotional support too. So once you develop rapport with a family member, you know, you can very quickly have a conversation. If you've never met that family member, those conversations went from 3 or 4 or 5 minutes to 25 minutes on the phone. That was very stressful for our care team, who are so naturally compassionate. Now they had to establish rapport on the phone, often not on video, and really convince the family that we were on their side, because the family couldn't see it, right? They couldn't see and touch the compassion in the room. So another thing we did was very rapidly, we ordered 600 iPads for the system, and were able to put an iPad in each room and an iPad outside the room so that care providers could communicate with patients without having to change their PPE. But then the family could FaceTime or could text with the COVID patient in the room. And of course, they had protective wrapping on them and could be used over and over again. So we found ways rapidly to help the situation, but we've learned a lot. And I think we'd love to spend a few minutes telling you, what have we learned from COVID, Lauren, and what are we going to inspect in our new design that maybe we didn't have in the plans already? We have committed to increasing our campaign goal from 109 million to roughly 120 million. Atlantic Health System will be matching 50% of that, so the foundation will raise 60 million. They'll put in about 60 million, but how is that going to be spent, and what do we need in case there's a second surge or, God forbid, a new strain of something that comes our way?
So I cringe at the idea of a resurgence, although, it'll keep us on our toes for sure. We already had in the campaign, and, I'm sure that you've been told or talked a little bit about this, is 80% of the hospital was planned to become private rooms, which obviously would have been very, very helpful in this pandemic and certainly would be in the future. One of the things that we did actually have an opportunity to practice a bit was a staff acuity model room. So in the new project that we've been planning, we have these super units. And essentially what that means is for neuro and for the ICU, what we had was a unit whereby the patient stays in their room and all of the technology and the staff and support are modified as the patient's acuity progresses. So on day one post-op neurosurgery, you may need 2 nurses taking care of you. The second day, you might need 1. By day 3, you may need 1 nurse that could also take care of an additional patient. And so what we were able to do is practice a bit by flexing up our critical care beds, to 105. I think the most we actually even had was about 97 critical care patients, but we were ready. But what it enabled us to do is to shift the staff and the resources to where the patients were most sick. And so this almost did give us a little bit of practice and a comfort level with how would it work, because critical care typically runs on a formula, and this was a little bit different than that. So our super units, what we did was validate that our plans were actually spot on, and had we had those super units, we would have been in much better shape. But there is definitely a whole lot more that we will be doing in terms of building maintenance and airflow and from an engineering standpoint, because this time around we needed negative pressure. There's a possibility in the future we might need positive pressure. And so what we didn't have the ability to do instantly was flip a switch and make that adjustment, where more modern buildings that are built now are designed to have that flexibility. And so that is definitely something that would be incorporated into our plans. The size of the rooms, the equipment, the monitoring equipment is definitely something that, here we were using if we needed them, if visibility wasn't great. We actually created windows in each of the patient room doors. Engineering would take the door off, put in a window and close it. I don't want anyone to think that we weren't going into the room and spending time with the patient. I feel like we're talking about a lot of reasons or a lot of ways to avoid. When we were in there, we actually were spending a lot of time with the patient. But what we wanted to avoid was running in and out, because it would impact the negative pressure of the room as well as the PPE burn. So what we were trying to do is to create as much visibility, but we used baby monitors at some point. So, yes, we had the iPads, but, there's other opportunities in terms of having the ability to monitor patients from outside of the room, from central units, where we'll have more capacity to do that moving forward.
We had one of our employees drive to the Bronx several times. There was a Target there that had baby monitors, so they had to be fresh, brand new ones. So he would drive there at night with his wife and bring us back baby monitors.
Right. The other thing is the operating room. So, even though we didn't have elective cases or scheduled cases coming in, patients still did have gallbladders and appendix. And, there were still patients that, required surgery if they had COVID. And so what we really needed to do was to use our isolation rooms within the PACU and in the operating room, having designated places we'll have the ability to do more of that moving forward by expanding and increasing the number of operating rooms and recovery spaces. And I think understanding or having a greater appreciation for a viral, a viral spread will give us a lot more food for thought in terms of the design and build of our new operating room suites.
We did deliver 300 babies during the surge.
We did.
And the maternity unit, we're getting a brand new state-of-the-art, state-of-the-heart maternity center as part of this new project. And the chair of maternity did say, I want monitoring and gases in every room. We didn't have that. So just those learnings, the maternity area was one of the few COVID, non-COVID, with the exception of oncology, sort of they coexisted together in a very safe way, but there was a lot of learnings that we can pull of what did you need, how do you change the rooms, how do you clean in between, how do we all feel comfortable that a patient that was COVID and now there's a new mother baby in there, that they're safe. All of those learnings we will pull through, and we're documenting that journey now. It's really wonderful to be on the other side, and hopefully our team members can get some rest, though they feel very guilty actually when they're not here. And I think it'll take some time for that on-demand feeling of critical care to subside, and where they can trust that they can go take a nap and we're all going to be okay. But we're extremely grateful actually for the learnings of this journey, for the community response, and I hope you all know that if you need anything, Overlook stands ready now and in the future. And we are truly grateful for the community's faith in us, and we hope we delivered and exceeded their expectations.
So what could you expect if you walked into the hospital now? And I think that that's, a fear that a lot of people have.
Yeah.
We've been coming and going every single day. There are people that are petrified to step foot in a hospital right now, thinking that's the worst place that they could be. And, I may be a little bit biased, but I will tell you it's probably the safest place that you can be. So as you're walking into our front door, we've made an investment in a thermal camera, very similar to what they were using in Vegas, at the beginning of this or just before it. And essentially, you don't even have to stop. No one has to take your temperature. As you're walking in, it is actually scanning you through a thermal camera technology, and it'll only flag anyone that has over 100 degrees, in order to identify anyone that has a potential fever before entering the hospital. We do have colleagues that are standing out the front door asking about signs and symptoms. There are people who do actually come to the hospital, believe it or not, sick because they need to seek care, but we want to make sure they're going to the right place and isolating them so that those of us that are healthy are not going to get sick by having that interaction. So we've been pretty clear about our visitation. We've been rather limited. At the very beginning, we actually had to put up signs outside that said stop. I mean, it probably was a little nicer than that, but no visiting, no visitation.
Yeah.
And Alan Lieber had asked me, Lauren, are you okay with it? And I said, absolutely not. I am totally against this. It goes against every fiber in my being to tell people that they're not welcome and that they shouldn't be coming into my home. And the truth is that we did it and we followed, direction, and it was the right thing to do. Our feedback from a patient experience standpoint has been outstanding.
Yes.
And, you would think that obviously going through something like this and, we had to, cohort patients. So a lot of patients actually had to share rooms with other patients. And you would think that that would have dramatically decreased our patient experience scores. And actually they've never been higher. And I think a lot of that has to do with the compassion, the communication, the extra efforts that have been made to make up for a lot of the things that we weren't able to do. But even from, those blowers, those silver tubes that were coming out, they actually create noise. And, noise is one of the things that we're tested on or, questioned about. And there were no noise complaints. And it was a white noise. So, maybe because it was constant, it wasn't an irritant. Yep. But the feedback and the compliments that we've received and the shout outs that we've received and, have been really, really remarkable. And I can assure you that this is safe. We are safe. We are cleaner than we've ever been. Quite often you will come into the hospital and you will hear someone playing at one of our 2 grand pianos. And it's just because it's just that, it's a lovely environment and we're trying to create a sense of calm and confidence.
We will be, based on this, pumping white noise into the hospital as part of the new construction, because it turns out that constant noise is soothing and people sleep better.
But not with the blower.
Not with the blower, but it'll be like a noise machine. But even those little things, anything we can do to inspect that into the design versus put it in later, which always costs more money and is harder to do, we are ready to do. And the foundation is geared up. Our board is so proud and so energized to continue fundraising and really to make sure that we are more than ready for the next time, whatever that is.
And you've donated more Xenex machines.
That's right. We also have 2 Xenex germ-busting robots. One was purchased by Overlook Foundation, the other by Overlook Auxiliary, our sister organization. And so those robots go in and deep clean a room. In between patients, it takes about 20 minutes.
Mm-hmm.
And you may have heard a lot about those, but you will see if you're driving by flashes of purple light, it looks like a disco ball going on. And that's the Xenex working so that we can turn the rooms over.
Right.
We
So
now
now have 5.
So we are ready for you, healthy or sick.
I believe this means it's time for questions. Is that right?
Yes.
Yes.
Okay.
Happy to answer.
All right. Bill, you have
Yes.
something that you need to say.
Well, no, I have a question.
Great. Hi, Bill.
Thank you very much, ladies. You know everyone's so proud of what you've done, and it's a great source of, peace for us on the outside to know that we have a quality hospital to go to. My question is about the issues around sourcing PPE and ventilator shortages, hospitals having to compete with each other. What do you feel the lessons you've learned for the next time around? What about the role of the federal government in this process?
So I will tell you, our lesson learned is that we are, and I don't really like the word stockpiling, but we are definitely accumulating resources that we have on hand in a warehouse so that if there are supply chain challenges, that we will not be as dependent on a very fast just-in-time inventory practice that we once did have. In terms of federal stockpiling, I think that there were some resources there, but we didn't want to count on them. I think that Atlantic Health, because of our credit rating and because of our relationship with vendors, was not in as vulnerable a position as some of our other colleagues out there. We also had the ability and success in sharing resources across the system, whereas a lot of systems, each hospital is competing with one another. Right. I can tell you also overseeing pharmacy, if one of the hospitals had more of a particular medication than another hospital and another hospital needed it, we were shifting our resources and supplies across the health system based on need. Or if 2 hospitals ended up using one particular medication so that the others could use an alternative and that we had enough of each that way, we were very effective in managing our medication supplies. But we also had a number of board members that were able to be very supportive and help us in terms of that. But we definitely will have more supplies on hand, and we have purchased many more ventilators than we'll hopefully ever need, so that we have them and own them as a health system, as opposed to looking to rent them or borrow them or rely on a federal stockpile for such equipment moving forward.
And this was another instance where the community was really extraordinary. In the second week, where it was clear that we were not just going to have 5 or 10 patients, a large bank in New York sent over their personal stockpile for their executives. So we got thousands of N95 masks and surgical masks and gloves, and several other pharma companies who are local, who've been working with us in the past, did the same. We had 7 Chinese American communities from as far as Princeton purchase PPE at God knows how much money, right? Because everybody increased the prices. and they would pay the custom fees and then deliver it to Overlook. So we were very, very grateful that the community assisted. And there were times where really it made a huge difference from one night to the next morning to make sure that our team was safe and could change as often as they felt they needed to be safe.
Thank you very much.
Paul is the next questioner.
Hi, everybody, and I'd like to also echo Bill's comments. Thank you so much for an absolutely wonderful presentation, very inspiring, and of course, it's so impressive the work that you are doing there, and we are really grateful that you would come and spend this time to tell us all this. But I have one very simple question for you. A lot of people on this call, I think, know what negative pressure rooms are, but a few might not know, and that's obviously that's a key part of your strategy. So could you take a moment to just explain that?
Sure. So what negative pressure means is that you would be sucking air out of the room and there's technical terms for it, but removing the air and creating air exchanges so that you're removing any of the particulates or anything in the air that would not necessarily happen without those air exchanges. So negative pressure is essentially removing the air and replacing it with fresh air at a particular speed in order to make the room safe for people to breathe and to reduce viral load or any potential for contamination.
Thank you.
Sure.
Haas, it's your turn. You have to unmute yourself.
Yep, I did. Good morning. Thank you very much. From a personal perspective, I had to use facilities of Morristown Memorial Overlook Hospital for since August of last year because of a stroke. And I thank you very much for all the services. General questions. If you look at the whole, I know you folks have done a tremendous job, but if you look at the whole coordination of PPE, things like that, it is more, you can write a book on how not to manage things in this country with all this brain power we have. That's a discussion for another day. But the question I had was Atlantic Health System. Most of your discussion was based on Overlook. I know you got a couple of other foundations, Morristown, Chilton, Newton, Hackettstown, so on and so forth. And I know that Brian Gragnolotti is the CEO, Alan Lieber, president. Are these worked as the individual units? If that's the case, you can understand the dysfunctionality we had throughout the country. So what kind of coordination was done? So the second part of the question, what Atlantic Health System Overlook is doing in the area of R&D? For example, 60 Minutes had a segments on, I think it was Hackensack Medical Center, where they were separating antibody plasma. Is something similar to that going on? All the work that's been done, that's great. But we can do better, a lot better than what we do. So what's Atlantic Health System doing, looking forward, planning?
Right.
We got through the tsunami. So how are you going to fix it and make it better?
Great.
Yeah, so I'll take the first step and I'll let the PhD take the second step of this one. So first and foremost, there was a daily morning call, and it was very early, and all of the hospitals were on that call sharing their numbers, how many patients they had, how many beds they had, what their priorities were for the day. So we were able to share a lot of best practices. We were able to shift resources where necessary. The way Atlantic Health is structured, a lot of the service line oversight covers the entire health system. I'm responsible for the laboratory and pharmacy for the entire health system. So all of those managers report up through me, and we had daily conversations and many daily conversations in order to make sure that every hospital and the needs of each hospital were covered and addressed and prioritized to the best of our ability. So there was a lot of shared resources and expertise. And so yes, while we're representing and talking a lot about Overlook, the same activities were taking place at each of the hospitals.
And we had the largest concentration of critically ill COVID positive patients, and I think that learning was spread out through the system very quickly.
Yeah.
So as for R&D, as I said, we were in 5 clinical trials. that are registered, so lots of learnings there. We are about to start a new COVID-19 neurology research trial to really look at the impact at the blood vessel level. Why is stroke so prevalent? Does age, are there comorbidities that we can be aware of to help manage? I mean, there's a whole population health to do, which Atlantic Health System is going to start to really focus on, which are what were some of the conditions that as primary care physicians, we now need to help the public manage. We need to clearly identify what those are and then segment our own patients into some risk categories and help them, whether it be being overweight, diabetes, heart disease. You know, it was always an imperative to get people healthy, but now knowing who's truly at risk for something like this, it puts a little bit more intensity into finding tactics that resonate with people to help them manage their health. And that's a really big research and development takeaway.
But
Just
the
a
other piece,
last follow-up question. You folks being in the field, is there any critical thinking, critical mass? You know, you folks have gone through something which we have not gone through, I don't know, in the last 50 years or so, to say, hey, there's a better way of doing these things. Is there a forum or some discussion going on within the medical community? I know if you look at the American healthcare system, it's probably the best and the worst. So
Yes.
a lot of things are there. So any thoughts on, you know, looking ahead? What can we do to make things better?
well, we are continuously looking at best practices, and there is a lot of data mining going on. I think with respect to our response in the care of COVID-19 patients, and quite honestly, I think it's been too short a period of time to actually have any, you know, appropriate, you know, research done on it in terms, you know, I mean, it was very difficult, or it would be very difficult from an ethical standpoint to say, we think this medication works. We're going to give it to you and not you, and you and not you. You know, I think that it's very, very difficult to implement any type of a really complex study over such a short period of time where there were not great clinical alternatives.
I think one thing we've learned, and it sounds ridiculous, but the importance of washing your hands, right? When I was little, I left the house, wash your hands. I came back, wash your hands. We've largely ignored that as a culture before COVID, right? You didn't see people walking into, say, a hair salon, and the first thing they did before they got their appointment is wash their hands. Right. From a global health and safety perspective, there is nothing better than washing your hands for 20 seconds. I, N of one, cannot underscore that has to be a new normal. When you go into a place, you wash your hands. Before you leave, you wash your hands, and you do that before you enter the next building. We're not really set up to do that. Are we talking about hand washing stations outside and inside? Maybe, but that is something, no matter how well off or how economically challenged a community is, that they can do, is access to safe water with soap for the public.
Mm-hmm.
John Tomaszewski.
Yeah, hi. Thank you. That was a good talk, but I may have misunderstood what you said. Did strokes and heart attacks go down during this crisis? Or,
yes, nationally, to almost zero.
Do you have any idea why that happened? Is it maybe because the older folks aren't going out and doing things, or do you have any thoughts on that?
Well, there were fewer broken hips also.
Yeah.
So there was that. You know, I think that there were definitely some incidents where individuals, especially with heart conditions, were not coming in because they were fearful. So they were either being managed at home, you know, but I do think that nationally, there was a decrease in prevalence of strokes.
Our chair of neurology jokes a little bit that it can't just be that everybody was under less stress. I mean, it can't be, because there were many people who were under extreme stress. We actually don't know. There are some people who believe that maybe our bodies go into pandemic mode, where we know there's some sort of motivating force to stay healthy. We can't really explain it. We did, however, see a direct correlation. As our COVID positive patient volume declined, the incidence of heart attack and strokes have come back up.
Yeah.
And it's not as though these patients were expiring at home from these things and we didn't get to them, we don't understand it. And I think that is a big global focus of research, is what happens to a society when you're under this kind of a pandemic strain. Now, people do not stop having babies.
Right,
That's
no.
one thing.
And there's going to be a lot more in the
There's
future,
going to be
I
a
think.
lot more in the future. But to be honest, it's people are joking about it, but it's not a joke. We don't understand what happened. We've even spoken to very in a casual fashion with our emergency management paramedics to ask, have you gotten to homes and people were dead? And they said, no, we didn't get the calls. We don't know. Is it a self-preservation mechanism? That's how I view it, but just N of one.
Mike Martin?
Yeah, thank you, ladies, for your outstanding service and Overlook's contribution to our community. I have really two data questions, which I think are important to the audience here. One, what was the most significant comorbidity with COVID patients? And two, what was the degree of, if you will, contamination to what you can share with us within the hospital, as I suspect, although not spoken, many of the people listening to this would have some fear of entering a hospital within because of this virus outbreak. Thank you.
Okay, so
Let's address the fear.
Okay, let's do the fear. The fear, first of all, is we test everybody coming in. So if you're coming in for a procedure and you're asymptomatic, you have no symptoms whatsoever, we are still testing you 3 days prior to your procedure so that we know whether or not you have COVID. And then we're telling you to stay at home and quarantine until you come in for your procedure. If you're coming in through the emergency department and you're going to be admitted, even if you do not have signs and symptoms of COVID and you were coming in for something else, we are screening you and taking a test there as well. So we know, essentially, there's more knowledge and information here than there is in your local grocery store in terms of who has it, because that piece of it really does help us to isolate and to keep our COVID positive patients separate and confined and isolated from everybody else. The other piece that you should know in terms of prevalence is that for our pre-procedure testing, over the course of, I think, 5 or 7 days across the health system, there have only been 2 positives. So we're probably running about 150 of those tests a day across the system. So over the course of 5 to 7 days, there's been well over 1,000 tests and there's only been 2 positives. So the incidence and prevalence is definitely significantly decreased. Now, I'm not going to say that there isn't going to be blips because of less responsibility from social isolation or distancing. But for right now, the numbers seem to be significantly lower, that there's less of an opportunity for catching it or spreading that disease.
And in terms of our own employees, did they get sick? Certainly early on, we did have some employees become ill, which said to me that COVID was probably in the community and being passed in a community fashion earlier than we know. There is some anecdotal evidence that it was here as early as October. Some emergency room physicians have reported casually to each other, there was that weird virus that was happening around Halloween. Remember, it was like this, but we didn't know what it was. So yes, we had some employees got sick. They were immediately tested and isolated and removed from caring for patients, as were their spouse. We do have residents who are married to one another. They would both isolate at home. Once we understood what PPE worked and how to use it to its maximum efficiency, their incidence has gone, as Lauren said, to very low levels. But our cross-contamination was probably early on when we were not quite aware of who had COVID and we didn't have access to the tests in-house. Right. So you could be caring for somebody And, you know, the initial news reports were you were infectious only once your symptoms appeared. That turns out to likely not be correct, that you could be infectious a day or two before. So if you had broken your ankle and you came in and you breathed on somebody or coughed on them who wasn't wearing an N95 mask, you might spread that infection. So we've learned a lot. I think masks are here to stay is the lesson for us.
Okay, Eric Hausker is next. You have to unmute yourself. Eric? All right, I'm going to move on because we have so many people. Mort O'Shea, you have to unmute yourself.
Hi, excellent presentation. Thank you very much. Are you expanding the physical footprint of the hospital with the capital campaign? Thank you.
Yes, in 3 ways. The first is we're building a new children's center, which will be in front of the emergency department. So there'll be a single access point for all emergent care. If you're an adult, you'll continue to our existing space, which will be refurbished. If you are 18 or under, you'll go to the right to this brand new children's center, which will combine pediatric emergency care with an inpatient unit. That's the first. The second is the maternity center will be getting a new operating theater, so a proper operating room, 2 suites. Right now they're too small for all the equipment that they need to do C-sections there. And then the third is we are building a new 8th floor on top of the existing 7th floor, which will become one of our cardiology super units that Lauren described before. So those are within the actual 4 walls of the hospital. Behind the hospital, we're building a 650 bay parking deck for all employees. It will be the first time that anybody who works at Overlook who has a car can park on site. We take up over 200 parking spots around the town in various lots and side streets. So from a traffic management and workforce experience perspective, this will be a huge game changer. If you survey our employees, the only complaint that is consistent among almost all of them is the parking problem. So that will actually be done. Lauren, when?
We expect that we'll be up and running by October.
So we also spent a lot of money shuttling our employees around because
$1
of the
million
parking.
a year.
So from a cost savings perspective as well, we're going to reinvest in our infrastructure that way.
Eric Hausker, did you unmute yourself? Okay, moving on. Jim Blinn, please unmute yourself. Go ahead.
Hi. Yes, I want to echo what other people have said. A very informative presentation. Thank you. Unfortunately, I was there 3 times last year with my wife, so I'm pretty familiar with a lot of the things that go on there. I do say what an excellent staff that you do have too. The palliative, worked with the palliative people and the nursing staff. But the question I have is, there's in-room air conditioners. So how does that work with the negative air pressure situation and air circulation?
So the scrubbers that we had installed actually connected directly to those in-room air conditioners, because those air conditioners suck air from the outside. They're exchanges from the outside. So what we did was, when we installed those scrubbers and those silver tubes that came out of the hospital, those actually were, it was filtering the air out and bringing in new air from the air conditioning units. But what I will say is that in our new project, we will be re-looking at all of our air conditioning, because the ability to monitor temperatures in such a large building in an old facility is very, very difficult. So switching gears, it's like steering a ship. Switching gears from warm weather to cold weather and from cold weather to warm weather, it's a very, very difficult thing to do, especially when you're trying to adjust temperatures based on people's preferences. So those air conditioning units, I am hoping, will be replaced with a much more sophisticated HVAC system.
Eric Hausker? Eric? Eric, last chance. Okay, Al Aho, please ask your question.
Ladies, thanks very much for a wonderful presentation. And I must say I'm a big fan of Overlook since my 2 daughters were born there.
Oh, that's wonderful.
My question is standard electronic health records. What is Overlook's position on this subject?
So we implemented the Epic system 2.5 years ago. And we are using it. It's what's used among all the large medical centers in the country. So we're very proud to be able to share information in real time with places like Yale and Columbia. We can share laboratory tests, patients' films, and diagnostic images. It also provides every patient the ability to access their own information through an app. So we've been using that. We are right now in the process of not only using it, but optimizing the data that we get and changing that into information to share among the medical staff.
The other piece is that we've been able to drive a lot of order sets. Think about, even so COVID comes into this hospital, doctors are not necessarily all familiar with what are the right tests to order, what are the right medications and protocols. And, we had a lot of physicians who, like we said, with our chairman of cardiology and, surgical intensivists, what we were able to do is to implement order sets very quickly and very nimbly using the health system's resources for IS. So those same order sets were exactly the same across the entire health system. So also if we were shifting resources, there were occasions where we borrowed respiratory therapists from Morristown or shifted some of our staff to other places. Our electronic record is exactly the same across the health system. So the ease of use for everybody using that system was the same in that it was standardized across.
Thank you.
Rich Jager, unmute yourself, please. Moving on, Victor Garber, would you unmute yourself and ask your question? Okay, we're having a slight, oh, there you go. Victor, go ahead.
Okay, actually, I had a series of 3 questions. First of all, your financial model, I'm sure, has changed with this COVID situation. I'm wondering how you're able to survive and get reimbursed for care in this circumstances. Who's going to pick up the tickets? Is this going to bankrupt you or change your model going forward? The other one is maybe similar. What is your liability situation considering variations in therapy as going forward and somewhat better understanding of what's going on with this disease? And the last question, I don't want to overwhelm. How many patients have you had, and what is your demise or the mortality, and where did and was there a difference in the catchments? Like you have patients from Irvington that might be a lot different than patients from Berkeley Heights. And I appreciate your responses. Thank you.
Sure. So overall, like I mentioned before, we had over 1,000 patients that we took care of. 747 of those patients, as of yesterday, were discharged home or to a skilled nursing facility. So our mortality rate was actually, I would say, lower than a lot of other places that we could compare ourselves to. So in terms of the liability, I do believe that there are some insurances to protect the hospitals from a pandemic, and there is some pandemic relief. The finances, which of course is the part I am most comfortable talking about, I will say that we started off in a really good place, and from a health system standpoint and Overlook standpoint, we were, one, really, really strong to begin with. January and February were outstanding months specifically for Overlook. But, you know, absolutely, we were dramatically impacted by the reduction and elimination of elective and scheduled surgery, because that's one of the main ways that the hospital makes up for uncompensated care. The other piece that is a dramatic challenge for the hospital was the reduction in outpatient services. So our plan and strategy is to ramp that up as quickly as possible. You know, part of management and leadership is returning to normal as quickly as possible. So a lot of what we've been doing is even isolating and closing down and confining the COVID units so that we can get patients in here safely. All of our elective surgeries from the beginning, I think our mindset was June 1st was when we were going to be ramping up. Even though we have been doing surgery and doing some of our interventional work, those numbers are dramatically increased now. I want to say we did 160 MRIs, outpatient MRIs last week in our ambulatory imaging center. Bringing all of those patients back and gearing that up will be dramatically helpful. I think that there has been some, or I know that there's been some relief from federal government and pooling of money, but it's not going to come anywhere near where it needs to in order to make up for the increased expenses and obviously the decreased revenue, as we're taking a very slow restart, very similar to the economy.
And we are a not-for-profit health system, and as are our Atlantic Medical Group physicians. So our stakeholders is really each other. So, you know, we're not motivated by profit in that sense. However, whatever margin we do make, we obviously use to reinvest in the system. So I think the importance of the foundations at this point becomes very strong, because luckily all of the service lines do have a lot of philanthropic dollars that they can use to plug holes, whether it be through capital or programs or services that they need to fund. So we're very happy to be a partner in this effort. We also did secure a line of credit. So we are, we had done that when the pandemic, it was clear the pandemic was coming as a wave. So our employees right now, we're doing everything as business as usual, because that's, the community needs us. We have no choice. We have to figure it out.
But
Our meeting is officially over at 11:30, but we have a lot of questions left. So if our speakers would be willing to, we will continue the questions.
Okay with you? Yeah.
Even though our meeting is technically over. So Rich Yeager, you are next.
My thanks and congratulations on the compassionate and effective care that you gave. My question is, what are they telling you about a second wave of COVID-19 coming, and who are they? What source do you rely on to get that kind of information? Thank you.
They is, I don't even know who they is, to be honest with you, but I guess it's the New Jersey Hospital Association. There's a lot of business intelligence. We are watching what the rest of the world is experiencing. You know, well, I think we'll have some blips, or we're anticipating a couple of blips this summer. I think the focus is really on September. And I think that, you know, to some extent, September, October is more conversation because of the confusion between signs and symptoms of COVID-19, the flu, respiratory, other respiratory illnesses. So, you know, I think that it would be a combination in ruling out to know what to rule in.
Lauren, could you maybe tell them, you know, when in the height of our testing, what percentage of patients who had respiratory symptoms were COVID negative? It's really eye-opening, myself included, by the way.
The patient, the direct opposite, really.
Exactly.
So if you were positive for your respiratory panel, you were very unlikely to have COVID.
But we didn't, you know, we discharged a lot of people who were COVID negative. They were sick, but they didn't have COVID. So we're preparing for a lot of respiratory viruses, not just COVID.
Right. I will also say the lab testing is actually getting much more sophisticated. So where they come out with the flu test every year, they come out with the flu shot, obviously, but the flu test every year is produced, and they start ramping that up for supplies in September. Now what they're really looking to do is a more comprehensive test with all the panel that'll include the flu, RSV, and COVID, and all of the, obviously the coronaviruses.
So if you can get those patients early and isolate them, I mean, hopefully it's a second blip and not a second wave.
Yeah.
Ivan Jacobs has the floor at this moment.
I would like to thank our speakers, Lauren and Clelia. You were absolutely spectacular, and we're all proud of the work you've done and Overlook has done, and I'm attending on staff there and never been more proud of an organization. Now, the Old Guard Summit started around 1930, prior to your time, and since then we've had over 4,000 meetings. In the past, we've thanked our speakers, female speakers, with real orchids. We can't do that now, but we'd like to thank you with a Old Guard salute.
Oh, thank you.
Thank you.
And all we can really do is clap like this.
Thank you. That means a lot.
Thank you.
And Ivan, just so you know, we are one of 4 organizations in Summit that's over 100 years old. So we were together in the 1930s.
We will continue now unofficially with a few more questions. Larry Cunningham, you're next. You have to unmute yourself.
Can you hear me now?
Yes.
Yes, thanks, ladies. It was a great presentation, and it's very reassuring to know that the caliber of the facilities and the staff that's there. I will say that my wife and I are counting on it because we're expecting our first grandchild to be delivered at Overlook later this month.
Oh, wonderful.
Congratulations.
We're ready for you.
Yep.
2 questions, one simple, maybe one maybe not quite so simple. So the first simple one is, are you still accepting PPE donations?
Yes, we are.
Okay, because my wife has been making a bunch of the ones that are the decorative ones.
Yeah.
And then I also been able to donate a fair number through a former work colleague of mine who lives in Shanghai and has access to some of the Chinese-made ones.
Great.
I don't know that they necessarily meet all of the highest standards, so they still may be used as the regular surgical mask. But anyway, so that's the first question. The second question is, which is, I'm not quite sure. So if you have a person who comes into the hospital who is COVID positive and is displaying symptoms, do you have, without the vaccine in place yet, I guess what I'm trying to say, do you have the means to kill the virus, or do you try to buy time until the body can kill the virus through antibodies?
Right. So we do use, many medications really to treat the symptoms, and with antivirals, but similar to the flu, where people will, sometimes take Tamiflu, it reduces the duration of the illness, but not necessarily prevents or kills the flu. It's very similar in terms of how we have to handle or manage any viral infection.
So the end goal is to have the body be able to develop the antibodies to be able to move on then.
Yes.
Okay.
And a vaccine.
Thank you.
Thank you.
Okay, Jim Shanley is next. You have to unmute yourself. Go ahead.
Thank you, ladies. Hello.
Hi,
Jim.
Ladies, I've got 2 quick questions. One is the interface of your data system with an organization like Summit Medical Group.
Okay.
Can you access their data if I were to come in as a patient in the emergency room?
We can provide information to Summit Medical Group, but we cannot automatically receive.
However, the doctors here, so Summit Medical Group does have intensivists and hospitalists here who can access your records from Summit Medical Group as they're caring for you in the hospital.
Okay. Second question had to do with the main part of the pandemic. Governor Cuomo mentioned the fact that when somebody went on the ventilators, that their chance of survival was 1 in 4. Not a great batting average. I was just wondering what your survival rate is for similar situations, and if it's as bad as that, is there an alternative treatment?
I think the ideal situation is to avoid going on a ventilator. And I think a lot of the medications that we are working with in terms of remdesivir, Actemra, many of those medications and the expanded use of those medications is to hopefully prevent a patient from requiring a ventilator to begin with. The other piece that Clelia had mentioned before was the proning, and that turning a patient and taking the pressure and the weight off of their lungs could also assist in preventing from going on a ventilator to begin with. I don't know exactly what our mortality rate is once the patient is on a ventilator, but I don't think that it is very dissimilar from the experience in New York.
Thank you, ladies, for a great
ventilator, your mom's.
Next question, George, you have the floor, George.
Okay, thank you. Thanks for all the time you've spent on this and with us this morning. My question is, should we all go out and get this test to see if we've had the virus? And if so, how would it be helpful?
If you're curious to know whether or not you had it, it is a good validator, and I think that the tests are pretty sensitive and specific, so you would at least either know whether or not it was a yes or a no. Would it change your behavior in any way in terms of being less careful and less diligent in preventing yourself from getting the virus? No, or it shouldn't, because we don't know whether or not or how much of the antibody you need to prevent, and we don't know how long it lasts. So it would really be at this point probably more an answer to confirm whether or not you had it. You know, if I was at one of those asymptomatics and actually tested positive for antibodies and it confirmed that I either had the exposure or had it, and I lived to tell the tale and didn't even know about it, it probably give me a little confidence where there's been so much fear. On the other hand, it wouldn't change my perspective in terms of how to protect myself and the people around me moving forward.
I think what would be of interest if we were if we had the time and the bandwidth to do tracing, to really understand who got sick when and what was the cascade of people they touched who got sick. I think to me that's an intellectual exercise I'm very interested in, but it doesn't change how we prepare or how you should prepare.
So it doesn't, it wouldn't
We're
provide any.
about to end our meeting in another 1 minute. So Joe Messino, a very quick question, please.
More a comment. Can you hear me?
Yeah.
The day after Mother's Day, I spent 4 days on the COVID floor at Overlook, 10th floor, and I felt perfectly comfortable there. However, my family panicked and they kept calling to have me move to another floor. I was there for a high temperature and I was tested 3 times for the COVID. And as I say, I didn't mind it at all. And I had the bonus of seeing the sunrise up behind the Empire State Building.
Well, we're glad you're well today.
Right?
Right.
Okay, we are finished with the official meeting. Bill Tittle, do you wish to say anything in conclusion?
No, except tremendous thanks to the ladies.
Thank you for having us. It was really a pleasure.
Thank you. I look forward to meeting you in person sometime.
Stay safe. Bye-bye.